Thanks very much, Chair, and thanks to all our contributors. I'm standing in for our health spokesperson, Gino Kenny, today. First of all, can I thank all of your members and yourselves for the fantastic work that you have done under extremely difficult circumstances, whether it's ambulance drivers, porters, nurses, doctors, midwives, you know, the whole gamut. You've had a very, very difficult time, and unfortunately things aren't improving for you from what you're telling us, and I certainly am aware of the horror stories myself from the individuals who come in telling about hours and hours and hours on the trolleys, or months and months, or sometimes years on waiting lists. It's beyond shocking. I had somebody who was looking for community mental health care recently telling me that they wouldn't get it for 2 years, I think. For 2 years. I just couldn't believe it. You're facing a mental health crisis and you're not going to get seen by somebody for 2 years. And that's just a staggering level of dysfunction. First of all, I just want to ask Philny Hay and yourself, maybe as a working nurse in an ED department. It is a shocking thing that you've told us here today, that we only have safe staffing levels in 12 of 29 hospitals. 3 years, if I understand what you're saying, 3 years after it was identified that we had to address that as a matter of priority, only 12 of 29 hospitals have safe staffing levels. That is very shocking. Could you maybe, Phil and yourself, I didn't catch your name, but could you maybe just outline what does that mean? What does that mean, not having safe staffing levels? What does it mean for the patients? What does it mean for the staff? And could you maybe also, I mean, one of the things I'm aware is that people working in ED departments facing physical aggression and sometimes assault. I mean, is that one aspect of this, not having safe staffing levels, that the staff are actually putting themselves in very serious physical harm's way from possible assault or attack? So maybe you could say something about that. The other question I particularly wanted to ask is something that I took up and we took up during the COVID thing, was the student nurses and midwives and the failure to pay them on placement. And I just thought it was unbelievable, not just during COVID, but in a situation where we desperately need more nurses, that we are making it difficult for nurses to do their training, to get through their education, and what the knock-on consequences of that are in terms of our ability to recruit and retain nurses and midwives. And I'm aware, for example, that in the UK, if you're doing nursing, you get a £10,000 a year as a bursary. Right, whereas, and that was actually a cut that the Tories had implemented. It used to be 15, but I mean it's multiples of what nurses have to put, student nurses and midwives have to put up with here. So maybe you could first respond to those points. I do want to ask some of the others groups as well some questions if I have time, but maybe. Yeah.
Just give the
Karen, sorry.
You're fine, Karen. Sorry, Richard. No, I might let Phil start first, and then I can give the lived experience if that's okay.
Thanks, Karen, and thanks, Deputy Barrett for your question. I think the assault figures are fairly shocking. We've set them out in our submission. They were released under Freedom of Information. 7,600 assaults on HSE staff were reported last year. Now, that's only the statutory hospitals, and it does not include psychiatric hospitals, and it doesn't include community or the voluntary hospitals. So obviously it's much higher than that. But most worryingly is that half of those assaults were against nurses. And I think the staffing levels obviously contribute to an increased frustration amongst the general public, particularly when they're waiting. But also we have a higher increase in assaults against staff in paediatric hospitals, which is quite worrying. And we also have a higher incidence of psychiatric patients attending ED departments and waiting to be assessed by psychiatry, but waiting in the emergency department, sometimes for prolonged periods of time. And a number of examples can be given of those inappropriate wait times. But when you add into the mix that the first port of call for Gardaí, bringing patients with altered behaviours, drug abuse, etc., is into the emergency department, and the staff of the emergency department then have to deal with that. So it's an inappropriate area. Obviously, what we have sought and what we've sought previously is that psychiatric admissions are made first to the acute psychiatric units. And as you have pointed out, there is another problem in that our psychiatric services are not fit for purpose. And we have a lack of services in community services particularly. So that is a big problem. It's also a feature of drug and alcohol abuse, which unfortunately ends up in the ED department. So it is unacceptable. One of the things we would hope this committee would consider and look at is the health and safety legislation. We believe it needs to be revised and strengthened in order to protect staff working in these departments. Because as I said in our opening statement, when you work on a building site, there are very clear guidelines. And if those guidelines aren't met, well, then the site closes. And we have situations where over the reported figures of over 7,000 people being assaulted, some having assaults. One of our members had an assault last year that ended her career. And that simply is not acceptable. And that hospital remained open. She was on duty for 4 hours after the assault because there was nobody to take over from her. And her colleagues go back into the very same situation with no change the next day. So the legislation around protection for nurses, doctors, healthcare workers in emergency departments and in hospitals must be reviewed and strengthened, because it is not acceptable to have an inspection from a health and safety authority which doesn't recommend very serious improvements in the protection for staff working in these environments. If we can't stop people coming in, if we have no alternative for them, well then the protections of the workers must be strengthened and must be very, very obvious and clear to staff, because it is a feature of our health service that is extraordinarily unwelcome and should not be happening. You should not be assaulted as part of your work or part of your role. It simply shouldn't happen. And as I said, the numbers that are reported, the official numbers that are reported, only tell half of the story, because the assaults that were recorded did not include the voluntary hospitals or community. In respect of student nurses, absolutely. I mean, the battles we have had to get the McHugh report published. We had to protest at the Dáil in order to ask for that report to be published. It's now published, and we're still meeting with the HSE in respect of aspects of it. So everything is a battle when it comes to improving the conditions for nurses, from the student right up. We have an expert review of nursing and midwifery in general, which has just been issued to the Minister. We're waiting for it to be published. And again, it hasn't been published. There is a crisis in retention. There is a crisis in relation to the workforce and the conditions under which they're working. And it shouldn't be that nurses have to go on strike in order to highlight these issues. Most of the time they're highlighting the effects on patients, the negative effects on patients of not investing properly in nursing and midwifery. So to your point, we absolutely agree.
Yeah, and just in relation to staffing levels, how that affects, it's like, that means if you don't have the right number of staff, that means you don't have the right number of staff to provide the care that is required to these patients that are in the emergency department or on the wards. So that's care that's been undone, or care that may be missed. You have increased incidence of tertiary care, which will increase their length of stay. And if, things are being missed, especially with the elderly, there's an increased chance of delirium to happen. And so that in itself increases bed days as well, and increases mortality rate It's massive. And in relation to assaults at work, I've witnessed 2 in the last month. Like, that's crazy. And it's totally dumbfounded that we're in this health system, that this is happening. And I can quote too, everybody has a different day. It's horrendous, and the health and safety legislation must be changed and strengthened to support us to be safe in our areas of work.
I don't have any time left.
Another question.
So just to take on your point, Deputy Barrett, about the...
Could I just ask one other question, and then also you can come back and say what you're going to say. Just one phenomena that strikes me, and I just like anybody who really would like to comment on it, is when I hear about the overcrowding constantly in our emergency departments, I simultaneously am listening to the radio in the car, and I'm hearing advertisements for come to the Beacon or come to the Blackrock Clinic or whatever, and you can get emergency care here. And that's just, I mean, the clear implication is, if you're on the public system, you're going to a war zone in one of our public hospitals where you'll be for hours on a trolley and you'll be dealing with all these stressed staff. But if you go to a private hospital because you can afford to pay for private emergency care, you're not really going to have a problem. I mean, is that the reality? And to what extent does that reality say something about where we could get the additional capacity to resolve the problem that we have in our public health system?
I think those hospitals have a function to fulfil right now because they're decompressing the public emergency departments. If they didn't exist, you can imagine how much worse the problem would be. Granted, they do only operate at a limited time during the day. Some of them it's 10 hours a day, some of it's 12 hours a day. But if you took that volume from them to displace back into the public system, it would mean there would be even worse. But to be honest, those hospitals are really concentrated in the Dublin area. I don't work in the Dublin area. I work in a smaller Model 3 hospital in the country, and we have a critical need to recognise the importance and future-proofing these Model 3 hospitals. Patients in these areas, just because they live remote from Dublin, doesn't mean they deserve any less health care. And unfortunately, all of the resources, the majority, seem to be directed to large Model 4 hospitals. So when you are in a smaller hospital without all the services on site, the patients that come to that emergency department are the same types of patients that go to the larger teaching hospitals in Dublin. Except when you have a fracture and you don't have on-site orthopaedics, you're then involved in phone calls and remote consultations to refer on. When you have somebody who has a brain hemorrhage, you're trying to refer out to Beaumont. When you have somebody who's got a myocardial infarction, you're trying to get them into the PCI lab. All of this requires more resources in the smaller hospital, not less. And one particular issue that you started off talking about, the community healthcare. Community healthcare is available 39 hours a week. It's not available 129 hours a week. That's the majority of the time. When somebody has an acute need outside of normal hours, you ring an ambulance, they get brought to a hospital. There are 4 hospitals in the country, I work in one, that do not have on-site psychiatric services. Yet, when you call an ambulance, you will be brought there. When I've dealt with that patient and try and get them into the next part of their care, which is referring to a hospital 50 miles away, I call the ambulance service, they don't take the patient. They say the patient is voluntary, they're not involuntary, they should be transported by themselves, the 50 miles to the next hospital. Now, there are bypass protocols in the National Ambulance Service to protect the large Dublin hospitals, that they don't bring a paediatric patient to the adult hospitals in Dublin. They don't bring a labouring obstetric patient to the large hospitals in Dublin. There's a standardised protocol to bypass those hospitals. We receive those hospitals we receive those patients in the hospital I work in because we have those services on site. We do not have the psychiatric services on that site. So there should be a similar bypass protocol for people with an acute psychiatric emergency to be going to the places that have those services, not bring them to a smaller hospital which doesn't have the service and can't service those patients' needs.